Welcome to our next session, which is the Joep Keynote Memorial Lecture. We are very privileged today to have with us Dr. Joep, who is an outstanding HIV clinician scientist working at Cornell University Medical Center in New York City. I think that I'm delighted to be able to be here because Joep was not only a friend of Joep, but a very close friend of myself as well. I was hoping that we might be able to show one slide of myself and Joep, which goes back a few years, but perhaps this will not be possible. I would simply remind you that our dear friend Joep was the victim of a terrorist attack on an airplane almost 2 years ago while he was flying to attend the International AIDS Conference in Melbourne together with his wife Jacqueline, and both of them were brought down by a missile that destroyed the aircraft, killing both them as well as almost 300 other people. So this is truly lamentable. I am now very pleased to introduce Dr. Gulick, who is, as I said, an outstanding clinician scientist working in the United States. It is fair to say that Joep has been part of the success story that involves the development of antiretroviral therapy, and he is going to speak with us today on the topic of where we are going in the future in regard to treating HIV disease. Oh, here is the photo that I wanted to show you. You can see it's a decadent one. You probably cannot easily guess who is Mark Wainberg and who is Joep. I'll give it away. I'm on the left. I've got the young-looking face that you can recognize. I know that I looked a little bit younger in those days. And Joep, who also looks quite young, is on the right. So we all miss him. And without further ado, it's my pleasure to introduce Dr. Gulick.
Merci Marc, merci Alain, merci à vous. The future of HIV care. I have no financial disclosures. I'm really honored to be giving the Joep Memorial Lecture. The first time I met Joep, I had my name tag on it, said Dr. Joep Gulick, and he looked at my name and said, Gulick, you're Dutch. And I said, yeah, I am Dutch. And I smiled and I said, and I live in New Amsterdam, but we call it New York now. And he smiled. We were at a meeting back in the late 1990s designing a new clinical trial at the time for combination antiretroviral therapy. It was for treatment-naive patients. The backbone was dual nuke therapy with DDI and D4T, and then people were randomized to a third drug, either indinavir, nevirapine, or 3TC. And it's interesting to look back today at that trial, which was a baby step towards where we are today, and recognize that we don't use 4 out of 5 of the drugs that were in that study. Joep would have been very proud with this topic today, the future of HIV therapy. He certainly was one of the people that built to where we are today. What I'd like to do is to say, well, where are we today with HIV therapy, and where are we going next? And I want to take a viewpoint that includes both developed countries and also the global view. And I know Joep would have been proud to be here today. So where is ART in 2016? As we know, recent recommendations worldwide now say start treatment at all CD4 cell counts. We have 29 approved antiretroviral drugs, and as you know, they're in 5 broad mechanistic classes: the nukes, the non-nukes, the protease inhibitors, the integrase inhibitors, and the entry inhibitors. We have up to 10 recommended first-line regimens if you consult guidelines worldwide, but one standard strategy: 2 nukes plus a third agent, either a non-nuke, a protease inhibitor, or an integrase inhibitor. What are the properties that we look for in ART as we've been developing it? Well, certainly virologic activity is number one. We've come to realize how important safety and tolerability is, as we plan to treat people for decades. Convenience also is key for our patients to be able to adhere to these regimens. We think a lot about access and cost, and now we look to the benefits, both to the patients themselves in terms of life expectancy, and to others as treatment as prevention. So what I'd like to do is to consider each of these properties and say where we are and where we're going. Of course, we're all impressed now that the question of when to start ART worldwide is now. And this is a slide that shows you a summary of guidelines around the world, the US guidelines, the DHHS and the IAS-USA, the European, the British guidelines, and the WHO guidelines for low and middle income countries. And as you can see, one word really pops out from these guidelines, and that is recommended. So recommended to start with diagnosis of AIDS or symptomatic HIV disease or asymptomatic, regardless of CD4 cell count. Now, all these guidelines groups are looking at the same data, and realize that there are some subtleties here. So the two US guidelines say recommended. The European guidelines say strongly recommended for less than 350 and recommended for over 350. And then the WHO guidelines use the word strongly recommended, but also use the word priority in terms of CD4s less than 350. Antiretroviral drug approval. It is almost 30 years since the development of the first antiretroviral agent, AZT, in 1987. And we now have 29 drugs approved for the treatment of HIV infection. And you see the series of approvals over the last almost 30 years. The what to start guidelines around the world, again, we're all looking at the same data. They're summarized for you on this slide. And these are the recommended or preferred regimens. And as you can see worldwide, as we know, 2 nucleoside combinations, tenofovir with either one of its prodrugs, TDF or TAF, with FTC, or abacavir with 3TC. And you can see that's really consistent across the developed world guidelines. And then in combination with the third agent, either efavirenz and rilpivirine and NRTIs, atazanavir or darunavir with PIs, and the 3 integrase inhibitors. The situation is different for the WHO guidelines. As we know, 1 regimen is currently recommended for the world, tenofovir with 3TC or FTC with efavirenz. It's interesting to see how these guidelines have evolved over time, and some of the agents that were originally recommended have now fallen to alternative status or even dropped out of the guidelines completely. And you can see, for instance, the US DHHS currently recommends no NNRTI as initial therapy. And you can see, again, other guidelines having similar thoughts about efavirenz. Atazanavir also has dropped out of several of the guidelines for protease inhibitor. Why these changes? A lot of these result from head-to-head comparative studies and from toxicity issues. It's interesting to me to note that the guidelines really are coming together, however, worldwide. One set of guidelines that really took a giant step forward are the GACITA guidelines from Spain. And these were the original ones from January 2015, which took a bold step and said that the preferred regimens should only be integrase inhibitor-based, dolutegravir or raltegravir regimens, really confining the others to alternative status, the NNRTIs and the boosted protease inhibitors. I found out this morning these were updated recently, and TAF with elvitegravir is now also considered a preferred regimen. Will the world follow suit? Will we be recommending only integrase inhibitors as initial therapy? I think time will tell. So what about antiretroviral activity? Where are we? Where are we going? Andrew Carr from Australia put together this nice review a couple of years ago about virologic response rates over time in clinical studies. He put together 114 studies through 2012, and some of these had up to 3 years of follow-up, and these were intent-to-treat analyses. And what you see with the circles is each study is represented with the circle, and the size of the circle tells you the sample size of the study. And what we're looking at here is the percentage of participants with an undetectable viral load, going all the way back to the late 90s into close to today. So back then, about 43% of people across multiple studies were suppressed, and you can see that that percentage has simply improved over the years since. 78% by the year 2012 at the end of his survey. And it's fair to say that recent studies show that we've gone even farther in terms of suppression rates. So here's just a selective example of several studies. And as you can see, these are all in treatment-naive people, and hundreds of patients were enrolled in each, regimens that are all featured among either recommended or alternative choices. And over in the far column is virologic suppression rate less than 50 at 96 weeks or 2 years. And now you see that we are routinely surpassing 80%. So although cross-study comparisons can be fraught with peril, what you see here is response rates 80 all the way up to 94%. So routinely in clinical trials, we are anticipating rates better than 80% today in 2016. And in fact, we now have comparative studies among some of the first-line recommended regimens. And for instance, the ACTG study, the single study, the Flamingo study, again, hundreds of treatment-naive patients randomized head-to-head with regimens that are featured in the guidelines. And as you can see again over on the far column, suppression rates to less than 50 at 96 weeks, we are now seeing some regimens showing statistically significantly better response rates, and those are marked with a star. Of the studies selected here, each of these is an integrase inhibitor, outperforming either a non-nucleoside or a boosted PI. All of these studies have been done in the last 1 to 3 years. How will these influence guidelines? Will this lead us in a new direction? Again, I think time will tell. Well, those are clinical trials, and a point that people often make is that what we see in clinical trials may not translate as to what we see in the community or in the clinics. But there's lots of data to suggest that we actually are seeing these kind of suppression rates across the world. One of the first groups to put together those data in the modern era is from British Columbia in Canada. And so they surveyed about 3,000 to 5,000 patients over the course of the 2000s and simply put together, of those people taking antiretrovirals in British Columbia, how many were suppressed to less than 50 copies. And they went from 65%, which is certainly respectable, but the most recent data that they published, that was all the way up to 87%. So this, again, is not a clinical trial. It's what's going on in the community. This is not unique to British Columbia. So we have recent data from the United States from a cohort called the Phoenix cohort, which is 8 different HIV clinics representing close to 30,000 US patients. Again, not a clinical trial. And percent suppression rates go from about 30% in 1997 to close to 90%, 87% to be exact today. Again, in a large population of US patients. Factors that were associated with suppression in this study after 2010 were older white men, better adherence, and interestingly, integrase inhibitor use. My own city, New York City, recently put together the suppression rates for all of New Yorkers, or a representative sample, taking ART, and look at the sample size here. 62,000 New Yorkers taking antiretroviral therapy. What was the suppression rate in clinics across the city? And it was 85% just a couple of years ago. And then they went on to publish hospital-specific rates. So I couldn't resist showing you our own data. Here's Cornell, close to 2,000 patients on antiretroviral therapy. Our suppression rate was 89%. Below detection at Cornell. And again, we're seeing these kind of rates really across the world. However, there is one group of patients that still needs better therapies, and that is the group with multi-class failure. I saw a patient just the other day who presented on tenofovir, FTC, boosted darunavir, and dolutegravir, had a detectable viral load, just under 90,000 copies, and had a CD4 count below 100, so really was in dire need of changing his regimen to something that would be more active. I did resistance testing, and what you can see here in the nuke class, the non-nuke class, the protease inhibitor class, and the integrase inhibitor class are multiple mutations and phenotypic resistance, essentially across all of the agents listed here. I did tropism testing, and he was dual mixed, and he actually had a remote history of treatment failure on infuvritide. So this unique man has documented drug resistance essentially to all 29 available agents. Just out of curiosity, how many of you have seen a patient like that? Raise your hand. Very few. So these patients are rare, but they are in need of options as well. There are new drugs in development that are specifically being developed with drug resistance in mind. I'd like to preview just a couple of these. One is doravirine. This is an investigational non-nucleoside. It's active in vitro in the laboratory against viral strains with non-nucleoside resistance to some of the more common mutations, K103N associated with efavirenz resistance, Y181C associated with nevirapine resistance, and E138K associated with rilpivirine and etravirine resistance, and also active against combinations of these non-nukes. This has gone into clinical trials. The phase 1 data in a small number of patients showed that it was virologically active in treatment-naive patients, and the phase 2 data were presented at this year's CROI by Jose Gatell from Spain. It was a head-to-head comparative study of treatment-naive patients. All received tenofovir and FTC, and then they were randomized either to doravirine, shown in green, or the control arm of efavirenz, shown in gray. We're looking at the proportion suppressed to less than 40 copies here, and you can see at the end of 48 weeks, it's just under 80% of all patients were suppressed below detection. So that shows significant antiretroviral activity of doravirine, and drug-related adverse events were seen in about half as many patients, 31%, versus the control arm of efavirenz with 56% adverse events. So this drug is currently in phase 3 and moving forward. Drugs with new mechanisms of action should have activity even in people with multi-drug resistant HIV. And one of the classes that will yield new compounds are the HIV entry inhibitors. We've come to know this class well. HIV entry, of course, is a 3-step process. HIV recognizes the CD4 cell by binding to the CD4 receptor in the first step, which induces a conformational change in GP120 that allows binding to the second step to the co-receptor or the chemokine receptor, and then that allows fusion of the viral membrane with the host cell membrane. We're all aware that we do have a co-receptor binder inhibitor. It's a CCR5 antagonist, Maraviroc. That's an approved drug. We also have the fusion inhibitor infuvritide, but the one step that we haven't yet had a compound to interfere with is CD4 binding. A drug or a candidate drug that's in development right now doesn't have a name. It's called BMS 663068. It's a small molecule that interferes and binds to GP120 and interferes with it binding to the CD4 receptor. So a new mechanism of action should have potent virologic activity. So this compound is in clinical development. 068 is broken down to the active compound 626529, and as I said, it inhibits CD4 binding to GP120 by binding to the envelope glycoprotein GP120. The phase 1 study in 50 patients showed potent virologic activity. You can see after only 7 days of dosing at the highest doses tested, 1.5 log reduction as monotherapy. Interestingly, about 12% of patients showed no activity at all of this new compound, and it turns out that they had envelope polymorphisms which rendered this compound ineffective. So this may be another compound that we will have to screen for activity before using. This compound progressed to phase 2. This was recently updated at the CROI meeting by Edwin de Jesus from Florida. They picked a treatment-experienced group, although they defined treatment experience as at least 1 week of therapy on at least one antiviral drug, not the typical treatment experienced group we're used to seeing. They did pre-screen for activity against this compound and then gave everyone a novel backbone of TDF and raltegravir and randomized them to one of 4 doses of 068, or the control arm was boosted atazanavir. They presented the 2-year follow-up results. Suppression rates were 61% below 50 copies with the oral HIV attachment inhibitor versus 53% with boosted atazanavir. Adverse events were less common with the entry inhibitor, only 2.5% versus 10% with boosted atazanavir. In the US, the Food and Drug Administration gave this compound breakthrough status, saying that it fulfills a need that is not being met with other currently available drugs. That was awarded last summer, and it's currently finalizing enrollment to phase 3 studies in treatment-experienced people. So we look forward to those results. Another new mechanistic class are the HIV maturation inhibitors. This is the very last step where the virus buds off, and its proteins are in the form of long polyproteins, like the GAG polyprotein shown for you here. A specific cleavage of this polyprotein is required. What does that cleavage? It's the HIV protease enzyme, and once cleavage occurs, that allows for full maturation and infectiousness of this viral particle. Of course, we have many compounds that interfere with HIV protease, the protease inhibitors, but the new class of agents, the maturation inhibitors, inhibit this step in a different way. So they bind to the polyprotein, in particular 2 of the subunits, and then prevent cleavage by the HIV protease. So that's how the new class of maturation inhibitors inhibits HIV maturation and development. One of these, again, has reached the clinic, BMS 955176, binds tightly to that HIV GAG polyprotein and is active in vitro against strains with polymorphisms and even strains from people who have failed prior HIV protease inhibitors. This new class of compounds shows activity. Phase 1 was done in 40 patients, a dose escalation study as monotherapy. And again, you see at the highest doses tested with 10 days of dosing that they saw about a 1.5 log drop in virus, again showing that this new class has virologic activity. This proceeded to phase 2, and now they begin to combine the maturation inhibitor with other compounds. So as you can see here, it was combined with atazanavir with or without ritonavir boosting, and the combination regimen was compared to 2 nukes plus boosted atazanavir. And with 28 days of dosing, you see about a 2 log drop in virus. So this certainly supports moving forward with combination therapy with this new class of compounds, and phase 2B is in progress right now. What about safety and tolerability? Going back to Andrew Carr's paper, he looked at 114 studies, again through 2012 with up to 3 years of follow-up, and again shown for you here with the circles. This time, though, we're looking at how many people discontinued treatment because of adverse events. And so back in the late 90s, that number was up to 14%. But as you can see, it decreases over the decades after that time. And all the way up to 2010, only about 4% were now discontinuing due to side effects. As we all know, HIV drugs have become safer and more tolerable over time. Since Andrew's paper, we have a number of other studies showing even better rates or lower rates of discontinuation. And again, an ACTG study and several other studies looking at regimens that we use today and tested in hundreds of treatment-naive patients. And you see discontinuation rates less than 4%, anywhere from 3% on down to less than 1% with some of the regimens that we use today. So certainly safety and tolerability have improved over the last years. There are other approaches to addressing safety and tolerability. One of them specifically targeted the dose of efavirenz. This was called the ENCORE study, sponsored by the Australians, and it was a large study of 630 treatment-naive patients who received tenofovir and FTC as the background, and then were randomized to efavirenz, either the standard dose of 600 or a reduced dose of 400 milligrams. What they found was that the lower dose was non-inferior in terms of virologic activity and had fewer side effects. And this has been impactful and will likely appear in the WHO guidelines as an alternative regimen at the lower dose. Another way to address safety and tolerability is to develop drugs that are safer, and a drug that we've been talking a lot about at this meeting is tenofovir alafenamide, or TAF. It was compared head-to-head versus the older prodrug formulation, TDF, in a large study in over 1,700 treatment-naive patients. As published last year in The Lancet, it showed non-inferior virologic activity and the suggestion of less renal and less bone toxicity. A number of switch studies have also investigated safety and tolerability. Many of these switched patients on TDF to TAF, TAF-containing regimens, and those with GFRs over 50 in 2 different studies, including the largest switch study in our field with over 1,400 patients, did show improvement in both renal and bone markers. And then another interesting study presented by Anton Pozniak and published earlier this year target a group of patients with even lower glomerular filtration rates, 30 to 69, and again showed improvement in switching from TDF to TAF. What about other approaches? We've had the standard 2 nukes plus a third agent for some years. People have been interested in so-called nuke light or nuke sparing regimens. The first approach was to use a boosted PI with either 3TC or FTC, and 3 studies, Gardel, Ole, and SALT, all investigated that possibility. Gardel was initial therapy, and Ole and SALT were switch therapies, and they all compared a standard triple regimen, 2 nukes and the boosted PI, to 1 nuke and a boosted PI. And in each case, each of these 3 studies showed non-inferiority of the 2-drug regimen compared to the 3-drug regimen. And then a completely nuke-sparing regimen of a boosted PI plus an integrase inhibitor was explored in several studies, including second-line following failure of 2 nukes and a non-nuke to a boosted PI plus raltegravir, and as first-line therapy in the NEAT-001 study using boosted darunavir and raltegravir. These had significant virologic activity, although in both cases underperformed at higher viral load levels, that is greater than 100,000, and in some cases CD4s below 200. What about other 2-drug regimens? Well, one that's caught people's attention is the PADDLE study. This is a pilot study from Argentina. It took treatment-naive patients with viral loads below 100,000. I must emphasize it is a small study of only 20 people. They were given an open-label 2-drug regimen of dolutegravir and 3TC, and all suppressed to less than 50 by week 8, and all continued their suppression through week 24. We're anticipating further follow-up of this group. I understand the 48-week data will be presented at the IAS Durban meeting. Omar Swed is one of the investigators at CROI this year, estimated the HIV RNA decline in the 2-drug study, PADDLE, and showed it was about 2.7 log drop, and that compared with historical drops in 3-drug regimens with dolutegravir of 2.5 in spring 1 and 2.6 in single. While the cap of 100,000 would limit this regimen, we've been working in the ACTG on an expanded pilot study called ACTG 5353. It's actively enrolling right now. We are open to enrollment. It's 120 patients, and importantly, the threshold viral load level is less than 500,000 to be entered into this study. I got an email this morning that we have 85 people enrolled as of today. And so we're looking forward to finishing up enrollment on the study and presenting results soon. What about convenience? Well, we've made major progress, as we all know, in turning 20 pill regimens that were given every 8 hours to 1 pill once a day regimen. And now we've had that 1 pill once a day strategy for 10 years as of this year. It's been so popular that 1 pill once a day regimens were approved in 2011, 2012, 2014, and 2015, and one recently approved earlier this year. So we currently have 6 one pill once a day regimens. These have been popular with patients and popular with providers. Newer approaches are also making regimens convenient. We're all aware of the approval of atazanavir co-formulated with cobicistat and darunavir with cobicistat. The new drug TAF is also being co-formulated, and some of these regimens are now available. So TAF with an L-vitegravir, 4-drug, 1-pill compound, TAF, FTC, and rilpivirine, and then most recently approved in the US, and the most useful regimen potentially is TAF, FTC, and then you can combine with any third agent. There's another TAF co-formulation, TAF, FTC with boosted darunavir, all in one pill. This is currently in clinical trials. This would be the first 1-pill, once-a-day protease inhibitor-based regimen. Another new approach in terms of formulations are injectable drugs, and you've heard a lot about these, and it's generated a lot of enthusiasm. So rilpivirine is available in a long-acting injectable form, and cabotegravir is an investigational integrase inhibitor, similar in structure to dolutegravir, which also can be administered parenterally and has a long half-life, allowing dosing every other month. Cabotegravir currently is in study both for the treatment of HIV and, importantly, for prevention of HIV in the form of PrEP, and those studies are ongoing. Some excitement was generated by combining these two, so 2 injectable agents together. In this first study called Latte-1, they were given in their oral pill forms as maintenance therapy and shown to be able to continue to suppress HIV in people who already had suppressed viral loads with that 2-drug regimen. That paved the way for an all-parenteral maintenance regimen, and this was presented earlier this year at the CROI meeting. Latte-2 is the name of the study. It was in 309 treatment-naive individuals. They entered the study and went on 2 nukes orally, abacavir 3TC, plus oral cabotegravir. And they received that for 20 weeks. Of those that were suppressed, they were then randomized to several options for maintenance therapy. One was using the injectable cabotegravir and rilpivirine, dosed once a month. A second group, cabotegravir and rilpivirine at higher doses, dosed every other month. And then the third arm was continuing the oral agents. Here's the results. So the people that went on that initial 2 nukes plus cabotegravir, nearly all responded by suppressing their viral loads below detection. At that point, they were randomized to one of the 3 arms, but you can see we're looking at percent suppression here from the back of the room that all 3 arms overlap. And more than 95% of all patients on this study continued to be suppressed. This is really a step forward in terms of having a 2-drug parenteral regimen that could be given every other month that now has shown at least early data to show that we could continue to suppress HIV. Will this change our whole treatment paradigm? Well, perhaps not, but this offers real opportunities for some people who have problems with adherence. A new compound very early in development is also addressing convenience. So again, no name yet, MK8591. It turns out it is an adenosine nucleoside, abbreviated EFDA. It's a chain terminator. It inhibits reverse transcriptase, but does it in a novel way by preventing translocation. So a new abbreviation, NRTTI, is a nucleoside reverse transcriptase translocation inhibitor. It's active in the test tube against HIV-1, HIV-2, and multi-drug resistant strains, but the real interest is in how long-lasting this compound is. So there was some human data presented at CROI. Patients at time 0 took 1 dose of this compound and then were followed, as you can see here, for up to 10 days later and had viral load decreases 1.8 logs below baseline levels. So 1 dose of this drug persisted for as long as 10 days to have potent virologic activity. So this drug could easily be dosed once a week. So if found partners, this is perhaps moving to the future, perhaps weekly regimens would be something that could be accomplished in a relatively straightforward way in our field. They also developed an implant which gave this drug off, eluted this drug, and tested it in animals, in this case rats. And they could find evidence of the drug just by placing that implant with this drug inside. Up to a year later, there were still detectable levels of this drug from this implant. Is this the answer? I don't know, but I think this is where the field is going. Implantable drugs, injectable drugs, drugs with long half-lives. And in fact, there's already published data looking at implants for drugs we have today. So this is a picture of an implant. It's a TAF implant, and I'll show you some clinical data from an animal study in dogs. So here's what the implant looks like, and what you're actually looking at, the black represents the drug itself, so it's a TAF core, and then it's given off through these channels over time. So they tested this in dogs for up to 40 days. This is looking at the drug level. You can see it's relatively consistent over 40 days. So again, might this be the future? Might we be using implantable devices that elute antiretrovirals over time? Again, perhaps not the answer for everyone, but some patients may likely benefit from this approach. Access and cost. So I've already mentioned that the when to start guidelines across the world have really developed. This is from a review in New England Journal by Kevin DeCock and Wafa Sadr from 2013, and it's looking at different CD4 thresholds and what 3 sets of guidelines recommended, the US, European, and WHO. So recommended in green, consider in yellow, and do not recommend in red. But as we all know, this has progressed. So I added 2013 to 14, and then current recommendations are worldwide that we treat everyone. Now, guidelines are aspirational. Not all countries were prepared to follow these guidelines. These data are from 2014 showing what threshold around the world people are actually started in low and middle income countries. Green represents treat everyone, regardless of CD4. You can see there are a bunch of countries. Yellow represents treat at less than 500, orange less than 350, and red, there are several countries on this map, less than 200. So the point here is that guidelines are there. Not all countries can meet the guidelines, although this is changing over time and probably will continue to improve. Why the difference? Well, as we all know, cost is big. Currently, there's an estimated 16 million people across the globe who are taking antiretrovirals, and the bulk of them, as shown in the brown here, are in African countries. Cost may change quite a bit. And coming up, this is from a recent review from UNAIDS at the WHO, and what they did here was to look at compounds that are being developed in generic forms and as co-formulations, and predicting what might be for the future. And I'll draw your attention to one compound on this list. So this would be generic TAF, co-formulated with 3-TC and dolutegravir, again, generic dolutegravir. The estimated cost of this, according to UNAIDS, $60 per patient per year for this state-of-the-art formulation. Is this available now? Can you write a prescription? No, it's not available, but it's something that we look forward to. And I think I could hear your enthusiasm as for a drug that could be priced like that, which would be highly effective. So what about the benefits to our patients? We know these well. Life expectancy has improved markedly. One of the first groups to look at this was the Danish HIV cohort, and they published this paper in 2007, so nearly 10 years ago. And what they did was to chronicle in this cohort study in Denmark, what was the survival from age 25? And importantly, they compared it with population controls. So if you look at the median survival for Danish people from age 25, the average life expectancy is over 80 years. They first looked at the pre-HAART era, which they defined as 95 and 96, just before triple combination therapy became available. And you will remember that the median life expectancy was only into the mid-30s, and that's just 20 years ago in our field. Then they looked at slightly after the development of triple drug therapy, which they called the early HAART era. you can see the huge improvement that we all saw. So the median life expectancy now goes up to age 50. And then a third group looking at the life expectancy in the years 2000 to 2005, which they called at the time the late heart group. And you can see again the life expectancy increasing to nearly 65. But there was a gap here, and many people have emphasized this gap, but the good news is that this is 10-year-old data, and I found out right before coming to this conference that the Danes have updated this data. And here they are. They gave me permission to show you. So same colors from the previous slide, but now we add 2 more cohorts of patients. These are, again, looking at survival from age 25. Here's the group from 2005 to 2009, and here's the group from 2010 to 2015. And now you see that the median life expectancy for HIV-infected person treated at age 25 is now over 75 years of age and coming very close to population controls. This will be published in the annals later on this year. Well, the Danes aren't the only ones to have looked at this and documented improvements. This is from the UK SHEIK study. This was published, again, 5 years ago in British Medical Journal. What's the life expectancy at age 20? Of all Brits, UK women would live another 62 years, so that's into their early 80s, and men would live 58 years, so that's into their late 70s. And then they compared that to a cohort of people with HIV, nearly 10,000 of them, who started ART after the year 2000. And again, the lines represent UK men without HIV in blue, or women in pink. And I draw your attention to the green line, who were the healthiest people they looked at, people who started ART between 200 and 350. And their life expectancy from their model showed that the average increase was another 53 years, so now living into their early 70s. But again, things have gotten better. So updating these data was looking at a much larger group of people, so just over 21,000 HIV-infected people in the UK SHEIK cohort, but now much more recent, from the year 2000 to 2012. So let's take a look. Men in the UK, average life expectancy is 78 years, so that's without HIV, and women, 82 years. I draw your attention again to the healthiest group here. So these are people who started with CD4s above 350 and have suppressed viral loads. And after 1 year of ART, their life expectancy actually exceeds that of the general population for men. If you look at the same comparison for women, once again, after 1 year of ART, exceeding that of the general population. How is that possible? Is this a unique finding? Well, it turns out that we have North American data showing similar results. So this is from the NA North America Accord cohort. Combines nearly 23,000 HIV-infected people from the US and Canada who were followed over the course of the 2000s for 8 years. 1,600 deaths occurred, and then they used that data to model life expectancy. It improved over the course of the study, and by 2006-07, that 20-year-old was now expected to live into his or her early 70s. But then they looked at that specific cohort, those who started early, CD4s greater than 350 at the end of their cohort, and that 20-year-old could now expect to live 69 more years. That's into their late 80s. That's better than the general population in either the United States or Canada. So several studies now showing better life expectancy than the general population. How is that so? Nobody knows, but people are suggesting that it's because HIV-infected people get regular care. And so we're assessing them for everything else, for concomitant hepatitis B and C. We're finding it, we're treating it. Cardiovascular risk factors like smoking, hyperlipidemia, and hypertension are picked up early and treated because they're being seen for their HIV. Is that true? Well, there's some interesting DAD cohort data right from here in Europe, published a couple years ago, looking at causes of death among people with HIV, and note the sample size here, it's nearly 50,000 people with nearly 4,000 deaths. And we're looking from 1999 to 2011, and they saw some interesting trends. So people dying of liver disease decreased by more than 50% over this time period. And people dying from cardiovascular disease decreased over 65%. Again, suggesting regular medical care is good for people and helps people live longer. Life expectancy is not only improving in developed countries, but also across the world. And what you see here is life expectancy for representative countries for sub-Saharan Africa and comparing it with world life expectancy. We're going all the way back to the 1960s here, and you can see tremendous improvements in life expectancy from the 60s to 1980. And this was public health developments, vaccinations, more availability of antibiotics. And you can see the world's life expectancy improves, and all of these South African countries had improvements in life expectancy. And then look what happens from the 80s into the 90s to 2000. So life expectancy worldwide continues to increase, but takes a tremendous decrease in all of the sub-Saharan African countries. And this is due to HIV and the parallel epidemic of tuberculosis. But look what happens after 2000 as we begin to treat people around the world, and particularly in Africa with ART, and you see life expectancy going back up at the same time. So what we're seeing in developed countries is now translating worldwide. ART is not only good for the individual who's infected who takes it, but it's also a potent prevention strategy. We know that. We've known that for a long time, and that's from the decrease in perinatal HIV. So going all the way back to the 1990s, we know that treating a mother with HIV who's pregnant will decrease her risk rapidly of transmitting to her child. And this is US data, but it's looking at perinatal transmission. Those results were found in the early 1990s that one drug worked. Of course, today we would use 3. But note the tremendous fall in perinatal transmission of HIV in the United States. And today in the US, less than 50 babies a year are born with HIV infection transmitted for their mothers. And these kind of results have now been translated worldwide. So we knew very early on that treatment was prevention. Occupationally acquired HIV, with the advent of triple drug PEP, has also virtually eliminated occupational exposure. These again are US data. There's only been a single reported case since the year 2000 of a healthcare worker who was exposed to HIV on the job, who actually acquired HIV themselves. So prevention of mother-to-child transmission and PEP have been remarkably potent strategies in terms of decreasing transmission. And then came HPTN 052. You know these results well. Serodiscordant couples, over 1,700 worldwide. The positive partner was randomized to either treat or not treat. And at the end of the day, when they looked at new infections in the partners, 28 partners in the group that had not yet started therapy versus only a single case in the group that had started. And they went back and looked at that case and found the transmission likely occurred on the first day that their partner started ART. So if you do the math there, as we all know, 96% reduction in transmission. This is a clinical trial, but now we're seeing these results begin to be translated to the population at large. This gave UNAIDS their goal that we're all familiar with, 90-90-90 by the year 2020, which is just not that far away. 90% of all people living with HIV would know their status. 90% of them would receive ART. So if you do the math there, that would be 81% of all people living with HIV. And 90% on therapy would be suppressed below detection. And again, doing the math, that would be 73% of all people would be undetectable. We're now seeing places in the world achieving or even exceeding these goals. One of the early places that looks like they're on their way is Australia. So their numbers are 86% of Australians, and they estimate that there's somewhere between 25 and 30,000. So 86% of Australians know their status. 66% of them are receiving ART, and 62% altogether are suppressed below detection. So that's pretty close to what the WHO goals are. In my own country, the US, we do not do well if you look at the country as a whole. Note our denominator is large, 1.2 million United States people, Americans that are HIV infected. We're doing not a bad job with testing, so 86%, that meets goal, but we don't do a good job getting people into care. Once they're in care, we do a fairly good job getting them on ART, so 37% of the total, and only 30% were suppressed below detection. I don't have to tell you that the United States is a big country with lots of moving parts and lots of different localities that do different things, and a very disjointed healthcare system. I'm pleased to show you what New York City does next. So we have 90,000 people living in the 5 boroughs, the 5 parts of New York City, and our current rates are 93% of New Yorkers know their status, 83% of all of them are on antiviral therapy, and 72% of all New Yorkers with HIV are suppressed below detection. So that actually makes, or is really close to making, the WHO goals. We're seeing these kind of data now from around the world as well. In fact, our governor, my governor in New York, was the first public official to stand up and say, I want to get rid of AIDS in my jurisdiction. No one had ever done that before. He did this 2 years ago. How to do it? Diagnose and link to care, get people on treatment and suppress them, and if they're negative, give them PrEP. And so this is being rolled out in New York City and New York State right now. This doesn't just apply to developed countries. Developing countries are also beginning to achieve goals. Botswana is a special case, of course. It's a relatively wealthy country in sub-Saharan Africa. This was presented at CROI. They did a population-based random sample of 24 communities. So they talked to about 10,000 people. Of them, 2,700 had HIV infection. And of them, they estimated 82% were diagnosed, 86% of them were receiving ART, and 95% of those receiving ART were suppressed below 40. So if you do the math, 67% of all people in Botswana were estimated, with HIV, are estimated to be suppressed below detection. Again, that is knocking on the door of the UNAIDS goals. Lastly, this just was published earlier this month. Denmark has a small HIV population, but they specifically looked at what's happening with Denmark MSM over time. The purple bars show you on ART with full virologic suppression, going from 1996 to 2013. And in blue are undiagnosed individuals, and you can see that they've made substantial impact over time in diagnosing with people with HIV. Now, the WHO has said that they have an elimination threshold. What is the number needed to get to where we could actually say that the epidemic would burn itself out or go away or be eliminated? And they estimate 1 new HIV infection per 1,000 individuals. So what this publication that is published online right now in Lancet ID estimated for Danish MSM, they are currently 1.4 new infections per 1,000 Danish MSM. So very close to that threshold for elimination of HIV. In conclusion, what can we say? ART, it's highly active, as we know. Is it possible to get even more active than we have today? Maybe not. But for people with multi-drug resistant virus, there is room for additional activity. Safe and tolerable, we've done really well in the past years. As I previewed for you, there may be ways to make drugs even more safe and tolerable. Same with convenience, with injectables, with implants. We may see even more convenient regimens, once-weekly regimens. Affordable, I showed you some tantalizing data to say that we can do better, and maybe it's just around the corner with some generic co-formulations. Accessible, there is room. We're only treating about half the people on the globe who need ART. We need to reach the other half. Life expectancy, again, I showed you some tantalizing results that people are doing the same or maybe even better than the general population. And treatment as prevention, we now see, is working across the globe. And in focal areas, perhaps we're going to begin to see the elimination of HIV. I didn't consider some big things that could impact the future of HIV care. So treatment of immune activation and inflammation is an area of research that is quite active right now. I didn't really consider PrEP and PEP very much, other than to say that they will help and that they're being used. And I didn't consider cure at all. I'd like to thank you for your attention and just thank our supporters. And thanks again for inviting me to come to Marseille.
Thank you very much, Trip. This was an outstanding lecture, and I think that Dr. Joep Lange would be very, very happy to have been with us and to have heard you give this detailed talk on the future of antiretroviral therapy. I think we have time for just a few short questions, if there are any. So I have one, if there aren't any from the audience. And I guess it's a concern I've had in regard to efforts to diminish the dose of efavirenz from 600 to 400, because I've always looked at the data and come away with the feeling that there are two elements that are taking place that may offset each other. One is the potency of the higher dose versus, on the other hand, the diminished toxicity associated with the 400. And I just wonder if you could comment on that, because to go from that trial or those kinds of studies into guidelines, I think, is a bit risky.
So I think you bring up an excellent point. If I broaden it, we would say that potency is important and tolerability and convenience are also important, and there's some part of both that will lead to the successful rates that we've been seeing. In HIV, right from the beginning, those of us starting antiretroviral therapy way back in the old days, we had the oncology model. So we would dose escalate until we saw toxicity. After we did that, we began to do the opposite. So as we begin to see efficacy, sometimes we would actually decrease the doses. And so we did more of an infectious disease model than the oncology model. If you go back and look at how efavirenz was developed, there is an abstract, it's never been published, that looked at 200, 400, and 600 of efavirenz and showed similar response rates with two nukes. 600 was chosen because more is better, quote unquote, at least from an oncology point of view, and that's where that dose came from, and that went into phase 3. So I take your point. You don't want to sacrifice potency for better tolerability. Efavirenz may be a special case because of the history of how it was developed.
Jean-Jacques Parianti from France. I had a question for you regarding your expectation of life expectancy among HIV, because you said quite provocatively that they have a better life expectancy than HIV negative. And I wonder how they could plot Kaplan-Meier curves for patients starting treatment between 2010 and 2015 for an outcome which will come with, so I see it's Annals of Internal Medicine, so there's probably a methodology, but it's models. And the problem with models is that statisticians fall in love with their models, but they may not be true. So if you can comment on this, thank you.
Sure, I completely agree with you. A famous statistician once said, all models are wrong, but they give us things to think about. And so you're right, we can't plot out life expectancy for 50 years from people who are being treated today. We simply don't know. What they did was to retrospectively look at people and record the deaths over 10 years and then extrapolate in a model. So you're completely right that these could be false. Maybe they're not the truth. They give us something to think about. Stefano, my good friend.
It's not maybe a question, but I would like to have your thoughts. We discussed this at length yesterday at dinner. So my position versus treatment as prevention is very favorable. I know it works. From we did the first Petra study, I remember, in Uganda with mother-to-child transmission. This was 1994. So it works. Now, what I criticize a little bit, and this is why I'm now pushing for cure and a vaccine, is the idea that treatment as prevention alone will be able to curb the epidemic. Because they used, sorry for this, they used the model of vaccination to say, if you go above a certain threshold, you know, above 70% of the vaccinees, vaccinated people, the bug will not have a place to go, let's say. So they reversed this, say, okay, so now they use to treat the transmitters, not the recipients, okay? So that's a different thing. But while the vaccine lasts forever, or at least for some time, treatment do not last forever. So to really be this 9 to 73% should stay forever to curb the epidemic, not one day. Now we are using snapshots today, okay? But let's say in 10 years, if you don't have a vaccine, what will happen in 5 years? We know the retention in Africa, because this was done for Africa. So my criticism is that these are snapshots, they don't take into consideration the long term. And on the other hand, the one that you do not reach, this is what I wrote, and in fact, I've been accused to be a little negative, but I'm not negative, I'm just saying what are the barriers. The 30% of the 70, let's say the 27%, which is not, do not behave like the others, like vaccination is for all. I don't know if it, these 30% may be a 10 times higher transmitter than the 70% which is treated. Even one hyper whatever may transmit, you know. But I'm sorry, it's not a criticism to treatment as prevention. I think we need it because it increases access. Let's say the 70 increases access to treatment, which is good for the individual. But I'm not sure it will make down the epidemic without other interventions, preventive interventions.
I think we have to wrap up.
I gave a talk, but
you make great points. The only thing I'll say in response was it was just a couple of years ago when people would get up at the podium and say, we will never treat our way out of this epidemic. And I just thought some of these early signs are interesting that maybe this, with other things, could actually do that. But we have to end.
So thanks to all of you for attending this excellent session, and thanks again to our excellent speaker, Dr. Trip Gulick. And we all depart from this session with very fond memories of our wonderful friend, Professor Joep. Thank you.